Today we will do the nasopharynx. So nasopharynx is the uppermost part of the pharynx which develops from the foregut, and it lies behind the nasal cavity or you can say that anteriorly there lies the nasal cavity. So this is the cranial cavity. So this is the hemisection of the head and neck. This is the frontal air sinus in the frontal bone. This is the crista galli. This is the cribriform plate of the ethmoid bone. This is the lesser wing of the sphenoid. This is the anterior clinoid process. So this is the cranial cavity, the lower part. And below here lies the hard palate. Posterior to the hard palate is the soft palate. And here lie the three turbinates or concha: superior, middle, and inferior concha. So this is the posterior boundary of the nasal cavity. So nasopharynx lies behind it. Then here lies the body of the sphenoid bone with pituitary fossa. This is the sphenoidal air sinus in the body of the sphenoid bone. So this is the base of the skull. And behind this is the basiocciput. This is the clivius. And this is the foramen magnum. And below the foramen magnum, the articulation of the anterior arc of the atlas. This is the posterior arc of the atlas. Then this is the C2 vertebra, the body, and the odontite process. Behind is the bifid spine of the C2. So boundaries of the nasopharynx, they are the roof and posterior wall. So roof is continuous with the posterior wall and it is formed by the base of the skull, that is in the upper part, body of the sphenoid bone, and below this is the basilar part of the occipital bone. Basilar part of the occipital bone. So together they are called basiocciput or clivius. Then below it is formed by the anterior arc of the atlas. That is the first cervical vertebra. So this is the roof and posterior bone. And here anteriorly the nasal cavity, the posterior part of the nasal cavity, posterior nares. Then inferiorly it opens into the oropharynx through the opening that is called the pharyngeal isthmus. Pharyngeal isthmus. So that is how we do the roof and posterior wall, anterior wall, and inferiorly. And this is the lateral wall. So whatever we are seeing is the lateral wall. So we will take one by one the features of the nasopharynx after doing the boundaries. So as you know, it is lined by the mucosa and anteriorly here like the pharyngeal tubercle, and to the pharyngeal tubercle we know there is attachment of the superior constrictor and the pharyngeal raphe. So this is the pharyngeal wall, covered internally by the mucous membrane. So as we know, the nasal cavity is also having the respiratory mucosa. In its lower two-third, which is pink color, same respiratory mucosa also lined the nasopharynx. That is the ciliated columnar epithelium, the sensitive mucosa. All of the respiratory tract is having the ciliated columnar epithelium. Same epithelium is covering the internal side of the nasopharynx. The posterior one-third of the nasal cavity, the mucosa is pale color. In upper one-third, and same is continued in the nasopharynx. And this is the olfactory mucosa. Upper one-third and lower two-third is the respiratory mucosa. Same is also found. So that is the internal lining of the. Then comes the. First we will take the features of the roof and posterior wall of the nasopharynx. What features we see here? So in the roof and the posterior wall, the features are, first here lies the nasopharyngeal tonsil. So nasopharyngeal is the one of the constituent of the Waldier's ring we have done. So in the retropharyngeal space in the nasopharynx, between the roof and the posterior wall, there is a lymphoid collection is there under the mucosa in the roof and lateral posterior wall, covered by the mucosa. This is called the nasopharyngeal tonsil. And due to this, the mucosa is raised. In the upper part it is broad and in the lower part it is narrow. So it is a wedge-shaped elevation on the posterior wall of the nasopharynx we see. This is called the nasopharyngeal tonsil. In the adult it becomes atrophy. But in the children it is very active, and any infection of these lymphoid tissue or this is nasopharyngeal tonsil lead to the enlargement, and that condition is called adenoids. So adenoids are nothing but they are the diffuse enlargement of the nasopharyngeal tonsil. So whenever they grow anteriorly and downward in such a way that they may occlude the posterior nares. So now no air can go into the respiratory tract. So this posterior part of the nasal cavity is blocked. That is called the adenoid. So when the posterior nares are blocked, then patient will come with a typical that is called adenoid faces. So when you look at this face of the children, the face of the child, he is having the mouth breathing because he can't breathe from the nose. So a typical face of the child is looked in the adenoids. First is the mouth breathing he is taking mouth breathing, plus there is a running of the nasal discharge from the nose, because now the nasal discharge is not going into the GIT. It is collected here by the mucus of the nasal cavity, which keeps the nasal cavity moist. So now that secretion of nasal secretion is not going into the GIT, so it will dribble out and patient will suffer from running nose. So running nose and mouth breathing is the typical face of the child suffering from the adenoids. The second feature of the roof and posterior walls, in some of the individuals, there is a pharyngeal bursa. So what is the pharyngeal bursa? Pharyngeal bursa is the remnant of the notochord. As we know, it gathers from the foregut, and where the foregut ends, same is the point where the notochord ends. So notochord is related to the dorsal wall of the developing GIT, that is the foregut. So this notochord sometime in some individual invade the lower part of the nasopharyngeal tonsil and it goes in the upward direction. Into the substance of the nasopharyngeal tonsil. So this is because of the attachment of the notochord with the dorsal wall of the pharynx, which develops from the foregut. So this type of the invagination of the mucous membrane is called the pharyngeal bursa. Sometimes the mouth of this bursa is closed, and because of that the secretion inside, they enlarge, they are collected and they form a fluid filled sac in the pharyngeal bursa. So fluid is accumulated here inside the nasopharyngeal tonsil. So this may be found in some of them. So when it is the fluid is formed, then it is called the pharyngeal cyst. And in some other individual, the cells of the notochord in this pharyngeal bursa or the pouch they undergo chondrification, chondrocytes. So chondrification of the notochordal cells can also happen here in the posterior wall of the nasopharynx, because notochord lead to the derivatives of many structures, the neural crest. So that is another feature of the posterior wall is the pharyngeal hypophases. Pharyngeal hypophases. So what is pharyngeal hypophasis? Actually it is seen in the roof of the nasopharynx. And as we know, the pituitary gland is lying in the pituitary fossa, the anterior adenohypophysis, and the posterior is the neurohypophysis. Sometimes what happens, the mucous membrane of the pharynx is hanging from the posterior side or the roof of the posterior wall, and the histological examination of the cells of this pharyngeal diverticulum, which is coming from the mucous membrane, if you find the cells inside this pharyngeal diverticulum, the cells are similar to the adenohypophysis or the anterior pituitary. So this signifies that this pharyngeal hypophysis is the remnant of the Rathke's pouch. As we know, Rathke's pouch is the developmental of the pituitary gland. The same Rathke's pouch cells may be detached during the development phase, and they form the what is called the pharyngeal hypophysis or the pharyngeal pituitary, which is hanging from the roof and floor of the roof and posterior wall of the nasopharynx. So these are the features we see here of the nasopharynx. Then comes the floor of the nasopharynx. This is the floor. That is called the pharyngeal isthmus. This is the floor of the nasopharynx. So floor of the nasopharynx is called the pharyngeal isthmus. It divides the nasopharynx from the oropharynx, because we know this is the oropharynx. Because this lies the mandible, the superior and the inferior genial tubercles. From the superior genial tubercle arises the genoglossus muscle. So tongue lies over here in the oral cavity. So the communication between the nasopharynx and the oropharynx is called the nasopharyngeal isthmus, and it is guarded by what is called the passavant ridge. Passavant ridge. So passavant ridge is a raised part of the mucous membrane here due to the underlying muscle that is called the palatopharyngeus muscle. Palatopharyngeus muscle. So palatopharyngeus muscle takes origin from the palatine aponeurosis, and this muscle goes around in a U-shaped manner at the pharyngeal isthmus, palatopharyngeus, and the fold raised of the mucous membrane because of this muscle is called the palatopharyngeal fold. This is the palatopharyngeal fold. So whenever we start taking food, then this opening or the pharyngeal isthmus is closed by the contraction of the palatopharyngeus muscle and the contraction of the levator palati and tensor palati muscles and musculi uvuli, the muscle of the uvula. Then the uvula moves upward and it fits here between the gap of the palatopharyngeus. So anteriorly the tensor palati, levator palati and muscular uvuli, they will close the pharyngeal isthmus along with the contraction of the palatopharyngeus muscle. So that is the mechanism occurring whenever we start taking food. This area is shut up and no food can enter into the nasopharynx while we are chewing up the food. So this mechanism is because of the passavant syringe. So that is how we understand of the isthmus part. But in the case of the ninth nerve, damage or injury to the ninth nerve, it leads to the paralysis of the muscles of the soft palate. Now the uvula remains hanging even if we are taking the food. It is not contracting and closing the passavant ridge. Isthmus is not closed. And that led to the entry of the food from the oropharynx into the nasopharynx. Because this mechanism lost. Because the palatal muscles and pharyngeal muscles, they are supplied by the nucleus ambiguous, 9th, 10th and 11th trunk through pharyngeal plexus. They are supplied. So when the 9th nerve is not damaged or 10th nerve is damaged or the accessory nerve is damaged, so either of the three or all the three or all the two may be injured. The problem is here. Food will come while we taking the food into our nose. So it gives the unpleasant sensation and situation, and this condition is called nasal regurgitation. Nasal regurgitation. So that is because of the fade of the passavant syringe. So that is the applied anatomy related to this. Now comes the lateral wall, which is very, very important. So features of the lateral wall, they are, so this is the lateral wall, lined by the respiratory mucosa. Behind the posterior limbs, behind the concha, so what we see in the lateral wall, very important structure we see here is the opening of the eustachian tube. The cartilaginous part of the eustachian tube opens into the nasopharynx just 1.25, half an inch behind the posterior end of the inferior concha. Just behind and a little below is a triangular opening of the eustachian tube is seen here. 1.25 centimeter behind and a little bit below we find. and this opening is surrounded by a depression. It is not in line with the surface, but it lies a little below the surface in a depression that is called the fossa of the Rosenmuller. The first feature of the lateral wall is the fossa of the Rosenmuller. Actually, this fossa of the Rosenmuller lies on the superior and the posterior side of them. So here the depression is there, which is more prominent in this area. So this is called and this is tucked in. The opening of the eustachian tube is tucked inside the fossa of the Rosenmuller, is a depressor. And it is caused due to the raised mucosa fold. So mucosal fold is raised here in this area, roof and posterior wall. Because of this, the eustachian tube opening is tucked down, and this forms the fossa of the Rosenmuller. The drawback of this fossa of the Rosenmuller is during the introduction of nasogastric tube, So while we are putting the nasogastric tube from the nose, this plastic or fiber optic tube may go into the eustachian tube opening, because this area is raised, the fossa of the Rosenmuller, and this eustachian tube is depressed below the surface. So most likely this nasogastric tube goes into the eustachian tube, or it may damage the mucous membrane of the fossa of the Rosenmuller by the repeated forceful entry of the nasogastric tube by an untrained nurse. So while we are putting the nasogastric tube, the attendant should be trained that the tip of their nasogastric tube should touch the superior surface of the hard palate. When it will touch here, then the nasogastric tube will be automatically goes into the pharynx. If it is in the upward direction, then accidentally it may go and damage the eustachian tube opening, and it may cause infection. So that is the how to introduce the nasogastric tube into it. Second feature of this lateral wall is, first is the fossa of the Rosenmuller, second is the tubal tonsils. So we know tubal tonsil is also the one of the tonsil of the constituent of the Walde's ring. After the nasopharyngeal, the tubal. The tubal tonsil again is a lymphoid collection of the lymphoid tissue in the roof and posterior wall. Because of this, what happens? The mucous membrane is raised, and this raising of the mucous membrane will cause the tubal elevation. The tubal elevation is because of the underlying tubal tonsil. Then in the anterior part of the opening of the eustachian tube, two muscles are going. One is vertically downward, other is going towards the palate. So these muscles, the vertical muscle is called salpingo, pharyngeus muscle, and the anterior muscle below the mucosa, anterior to the eustachian tube, is called salpingopalatal muscles, because you go to the palate, soft palate. Salpingopalatal muscle. So these two muscles, they also contribute in the formation of the tubal elevation or the fossa of the Rosenthal. Then this eustachian tube is also the one of the sites for the infection of the middle ear. So middle ear infection is very, very common in the children, plus the internal ear also. Because we know any sort of the bacterial spores from the atmosphere can go into the eustachian tube and it goes into the middle ear. Usually this eustachian tube remains closed by the action of the muscles around it, but it may open in the case of the infection. So in the case of the common cold, that is rhinitis, the mucous membrane of the nasal cavity as well as the nasopharynx, which is continuous, is raised or swell up. The swelling of the mucous membrane around the eustachian tube closes the opening of the eustachian, and the secretion, mucous secretion, which is trapped inside the eustachian tube, will give rise to a heaviness of the ear of that side. So during rhinitis or common cold, you might have experienced the heaviness in your ear. It is because of the closing of the opening of the eustachian tube, because of the swelling of the mucous membrane around it. Then air is also trapped inside, and because of this there is a retraction of the tympanic membrane, because the eustachian tube opening in the nasopharynx actually equalizes the pressure outside the tympanic membrane and inside the tympanic membrane. But during this closure, there will be retraction of the tympanic membrane. So that gives rise to the heaviness in this. It is also experienced during the aeroplane. So whenever we go into the aeroplane, when it comes from the height, the atmospheric pressure decreases when we go up. Because we know atmospheric pressure is about 760 mm of the mercury. And the pressure inside the eustachian tube or the tympanic, in the tympanic cavity, is about 400 to 450 mm of the mercury. So high pressure and low pressure, it equalizes that is the function. So air is trapped inside the normal tympanic cavity, and there will be proper function of the tympanic membrane. But as we go into the height, the atmospheric pressure decreases and the pressure inside is increased. So what will happen? The tympanic membrane will be retracted inside. Normally it is still. Now it is retracted inside the tympanic cavity. Because outside pressure is low, inside is higher, 200 and 400. So this retraction of the tympanic cavity during the aeroplane ride, it gives a clicking sound inside the tympanic membrane. In the middle ear, we feel whenever the aeroplane goes into the height, there is a tick in the ear region. Similarly, when the aeroplane goes down, now the atmospheric pressure is increasing again. And during this part is also the air in the eustachian tube, the pressure is down and outside is higher, again there is a retraction of the tympanic membrane. And this retraction of the tympanic membrane, it also causes the unpleasant sensation. So in order to avoid this unpleasant sensation of the retraction of the tympanic membrane during the aeroplane ride, we should always keep the saliva in a deglutition form. So whenever you do the deglutition of the mouth saliva during your up and down position of the aeroplane, so deglutition will cause the muscles of the soft palate to contract, and passavants and the muscles around the eustachian tubules, they contract and they relax. So during the air intake, during our deglutition, so this will equalizes the pressure and it will open the eustachian tube and closes it and open it. So there is a rhythmic opening and the closing of the eustachian tube opening, and you won't feel any tick or any other heaviness sensation of the tympanic. So this is how the nasopharynx and the pressure in the nasopharynx is having a relation with the atmospheric pressure. So this is all about the nasopharynx.